Everybody, it's Steve the Hurricane here, and for today's episode of A Drink with the Hurricane, I am honored to be able to interview my longtime friend and United States Naval Captain, Dr. Joseph Coutura. So every single person out there, I want you to raise your glass with me and let's cheers and toast to your success. Cheers. This is A Drink with the Hurricane, the talk show discussing all things growing your home care business. This video is sponsored by Home Care Evolution, where we help home care agencies adapt to changing circumstances, transform their business so that they can thrive for years to come.
Thanks, Dave. Appreciate it, buddy.
You're very welcome, my friend. So how's it going? How have you been?
Doing well, doing quite well. Up here at the Pentagon, doing some work for the Undersecretary of Defense, and just really have always enjoyed my career, but this is a very new and exciting opportunity that I'm very happy to be a part of.
Dude, I cannot believe just our history without getting too personal, you know. But for those that don't know, Joe and I, we've known each other since we were like 10 years old, and we went to church together, and we kind of grew up through high school. And then I didn't see Joe for about 25 years. And then I'm literally going down an elevator to go to work out in the fitness center, and the door opens on what I think is the lower level, and it was actually the second level, and he goes to get on like 6 months ago. And we reconnected, so a lot of time has passed. But thank you so much for doing this. So this is exciting stuff.
Yeah,
and for everybody back home, if you haven't had a chance to read Joe's article in the Home Care Evolution Quarterly that came out a couple weeks ago, you definitely have to make sure you check it out. homecareevolution.com/magazine. He wrote a fantastic article on what veterans are looking for, and that's basically what we're going to be talking about here today as we get through everything. So, you know, Joe, you're not only are you a captain, you're also a doctor. And so will you just talk a little bit about like your experience? What's it like being both a naval captain, but also a doctor, and what are your responsibilities like that you can share with the audience here?
Yeah, sure. So my career has been I'm an emergency physician. So from the deployment standpoint, we deploy as far as resuscitative care providers. So very close to the injury shortly after they occur. We're usually the first line that will receive those patients, and then start the resuscitation, bring people back to a level that their bodies can sustain the injury, right, and hopefully prevent death, or if not prevent it, then prevent morbidity, like prevent the injury from getting worse, and then move them up the chain to a surgical unit further up, which is usually in a more protected area because the nature of their work requires them to be stable or stationary. Here in the United States and then overseas, a lot of our work is done inside military hospitals, or even sometimes civilian hospitals, where we're taking care of the beneficiaries, the people who have served their country or are serving their country, and we're providing them care across the care continuum. Whether, you know, obviously I'm an emergency physician, I work in an ER, but those folks get admitted, they get surgery, they get cancer, and we treat them like any other patient in any other hospital.
Wow. That's incredible. And I know from just things that I've seen over the years and the advancements in science and the healthcare continuum, I know that back when we were children in the early 90s, injuries that soldiers and military personnel would take in the field that would have left them where they would have passed away. Now they've been able to do a lot of like on-site triage and stuff. Like, for example, I think about landmines, right? And someone has a leg that maybe has been blown apart. That used to be a fatal situation. Now they're able to save the person and bring them back and stuff. Can you talk just is it okay if I ask you? Can you talk about some of the things that you've been able to be a part of with those advancements? Because I'm sure that's been a huge part of that.
Yeah, so I love the quote by Will Mayo, which is the only victor in war is medicine. And I would say the global war on terror offered us a tremendous opportunity to test resuscitative care in a way that had not been evaluated before. We learned a lot of lessons that were previously dogma, which were based on opinion and opinion alone. And for the first time, really, I would say, in the history of warfare, evidence-based medicine and peer-reviewed scientific journals became the cornerstone of how we delivered care. And what we saw was when we did a good analysis, we got a good product, meaning more people survived despite more injuries or more severe injuries. So the things that I've been involved in, tourniquet application, previous to the global war on terror in 2003, tourniquets were forbidden. Nobody was allowed to put a tourniquet on. If you put one on, you were probably going to end your career. Now, tourniquets are all over the place, so much so that we teach it to lay people in a class called Stop the Bleed. And I've taught tourniquet application to 85-year-old grandmothers. And then largely just how we do surgical procedures in combat. So, classical surgical training is that all care must be delivered at the time of initial contact. So shortly after the injury, you take them to the operating room and you might spend 4, 5, 6 hours, 12 hours, 14 hours operating on those patients. What we find now is that that's bad for patients in combat operations, that we really need to just stop the bleeding and focus on resuscitating the patient. So getting them out of this period of peril and into some stability, and then come back and readdress all that stuff. And that's a big change from how people used to do that type of care. We call that damage control surgery and damage control resuscitation. And it's 90% ICU care, 10% surgical care, when it used to be the inverse. But what we found was people were getting wound infections, and they were getting sepsis, and they were not surviving because they were cold and because their belly was open for 4 or 5 hours, and now they were losing heat, they were losing fluid. And despite these efforts of very talented people, you can't argue with physiology. It will win every time. And so by adopting these measures, we've been able to change the landscape of how people survive in combat, and we're imparting that to the next generation, people that are going to relieve me in medicine.
Wow, that is just so fascinating. I will say I am a lay person in the sense that I'm not a doctor, I'm not a nurse, I'm not anything medical. I've always been on the business side of providing care for people, but I still just am marveled at the way things have changed and evolved over the last 20 years of our lives, from, again, stuff that would have been fatal. And I love the way you said it. It's like we were doing what we thought was the best in the time, and it was, this is the way that we do it. But now it's like, wait a second, let's do the exact opposite of it. Let's stop the blood flow, keep the blood in the body, and then we'll take care of the surgery later on. It's almost like you said, triage, emergency room type of an application, and then save the surgery for later on, because we can do that. The person will have a better chance of surviving because that wound has been closed. It's not going to get infected and everything else. Amazing. Yep. So just shifting our focus a little bit towards the elder care side of things, right? And actually, you know what? We kind of just touched on this first here. So when I was doing home care back in my day, I was taking care of veterans of World War II. And now, not that there's still not veterans of World War II around, because there still are, but there are far fewer of them remaining. And now the healthcare continuum is starting to shift towards taking care of veterans from the Korean War and Vietnam. And when I say veterans of those wars, not that we're taking care of others, but it's the elderly population
right.
represent those two wars. So can you tell us a little bit about what these particular veterans, what are their concerns?
Sure.
What are their challenges? Because, I think back to when I was doing this with the World War II, that was the greatest generation that ever lived, right? That was their generation. So their expectations were very different from the next generation, which are our Korean and our Vietnam War veterans. So can you share a little bit of the insight, having worked with that population?
I think when you're talking about veterans, there's always a handful of people who are, have a bad experience in the military and are not particularly happy with their time spent. But I would say the vast majority, 95%, truly value their service. And even those that were drafted, maybe not, of free will, I think today a lot of the recognition that they were due has come to them. I think Korean War is hard because it's the forgotten war. Like, people say, "What do you mean we had a war with Korea?" And then Vietnam was really hard because it was the public war.
Unpopular.
Right. It was the public war, and these folks served at a time where it wasn't cool to be in the military, right? It's cool to be in the military now. It's cool to be in the military after 9/11. It was cool to be in the military during World War II. You were like seen as saviors, and you were not during Vietnam. So there is, I would say, some bad blood that remains, but largely, I think most of the people that I've encountered have been proud of their service, or have at least been proud that they answered the call when their nation asked them to. Like I wrote in the article, veterans are veterans, and I've had conversations with 90-year-old veterans, and there might be 60 years between us, but we share some of the same similar experiences of basic training and just the terrible times in the field where it's cold, you don't have great food, you're bored, and but you gut it out, and it's the camaraderie and that unifying concept of you're both in the military that really helps get you through that. And I would say if you're looking for a way to strike up a conversation, establish rapport with a veteran, asking them about their service usually goes a long way. I will tell you, if they are not proud of it, they'll let you know pretty quickly, and I would move on to something else. But I would say probably 19 out of 20 people are going to be proud of their service and are going to be interested in what you're asking them. And it's a great way to establish rapport with a vet.
I love it. Thank you so much for sharing that. And it's interesting because I know from from my perspective, not with dealing with the elderly and veterans per se, but rather with just in passing, whenever I see a soldier sometimes, or I keep saying soldier, I know soldier is I think army, right? So when I see a military personnel active duty, I will say thank you for your service, and they're just like, good, and then they continue to go on their way. It's not like they're doing it because they're doing it. They have their reasons for it, but it's just interesting to hear what you said, knowing my experience with that side of it. So that's fantastic and fascinating there. Something I want to ask you about, because it's just something it's kind of facing the whole nation, not just with the veterans, but I want to keep it to the veterans for the purpose of our interview here today. But we have the baby boom generation. They're the largest generation in the United States. With that being said, they're retiring at an alarming rate. They're the people that a lot of folks are concerned about breaking the healthcare system, because there's only so many people who can do the care, and there's more people who are going to need the care someday. What are some things that the government is doing, or what are your thoughts on how we can better serve and be prepared for all of these veterans and baby boomers who are coming along, so that we can meet this demand and still provide that positive outcome for our troops?
I think the biggest thing that the way that we can address this is talk to people, and ask them, what do you want? Having that sober conversation with people before crisis is encountered is critically important, because care is really expensive, and you will spend more on healthcare in the last year of your life. 90% of your healthcare will be consumed in the last year of your life, compared to all the years prior. And a lot of that care is futile. It's unfortunate, but and there's always miracles, and people do hang on for miracles, but miracles are pretty rare. I know these are really hard decisions, but having someone have a very clear, sober, conscious decision of when disaster happens and you're on a ventilator, do you want to stay on a ventilator? Do you want artificial nutrition, or do you want to be made comfortable and allowed to pass peacefully? And those decisions are important, not just from a morality standpoint, not just from a humanitarian standpoint, but also from a financial standpoint. We deliver a lot of futile care in the hospital every day. People don't get better. And it's unfortunate, but that is the reality of it. And the more involved people are in their healthcare, the better the product is going to be, and the more rewarding the relationships is going to be. I think you will find palliative care people who will tell you that they love their practice. I mean, which is, it's unusual that you would say, I love to help make people make this transition from life to death. But I know people find it incredibly gratifying and rewarding, because they are there for people honestly at the worst possible moment of their life, and for their families as well. And those conversations need to take place in order to prevent like a healthcare collapse in the near future, because we are quickly outpacing the care that can be delivered. We have doctor shortages, we have nursing shortages, we have hospital shortages, and we have more people that need care. And the people who need care can't always get it because somebody is in that bed and they're unlikely to get better.
You said so much there, and I thank you so much for that. And some of our listeners who watch these videos that I put out and these interviews that we're doing with people, they are in that palliative care. And everything that you just said resonates with them. I guarantee that there's going to be somebody who, when they're at this point, they're going to be like, that's exactly why I do what I do. Right. Something that I always say when I'm speaking at different conferences and conventions is people are called into healthcare. It's not just something that they just woke up and said, I'm going to be a nurse one day. Usually it's they lost a parent, they had a friend or something, just in many ways, almost like the military, where you're called to serve. There's this calling to serve in a different way. And so it's to serve at the end of life and to be there for that patient. And you hit the nail on the head. Preparedness, having the conversation early. You reminded me of the Pulse movement, the physician's orders for life-sustaining treatment. And I was a big advocate for that when I was on the providing care side of things. And I spent a lot of time with different physicians around the country to really put things in place to be able to find out how to treat the person and what their desires are. We could keep you alive on a ventilator and a feeding tube for years. Is that what you want? Or what are your desires, Mildred? Well, I want to be alive to see my grandson make his bar mitzvah, right? Okay, we can do that, but I need you to do X, Y, and Z to be compliant, and then we'll get you to that, and then we'll do everything else. Like, there's so many amazing things that come with that Pulse movement there. So I love what you're saying, and it's all about the readiness. A stat that came to mind from those days, and I'm sure it hasn't changed much to your point about the finances. Every state around the country, and it has to do with how they view life and death and also legalities and such too. But to your point of the last year of life, people spending more money than pretty much any other year on their health. You look at a state, it's okay. You look at a state like where we're from, New Jersey, we're like 49 or 50 out of 50 when it comes to the most amount of money spent on somebody at the end of life. And we also have some of the poorest outcomes, right? With pain and suffering, because we're trying to continue to treat the person when they're no longer able to be treated, instead of helping them to be comfortable so they have better quality of life and they actually live longer. On the flip side, I believe the number one state, and this is the data's old, was Utah. And Utah has a healthy outlook on afterlife and everything else. And so therefore, by cost, they spend less money than the other states, and people live longer than any other state. So it's interesting, to your point, treat the patient, treat the pain and suffering and the comfort if they're aware of it. Let them make that conscious decision, as opposed to giving them futile care where they're only ultimately going to pass away anyway.
One of the other things I think bears some attention on this is culture. Right? It doesn't surprise me that Utah doesn't spend as much money on healthcare as the Northeast does, because having been to Utah many times, it's a very active population. People are golfing, people are skiing, people are running, people are biking. The weather, for the most part, is pretty reasonable. Yeah, you go up in the mountains, it's going to get cold and snowy, but down in the valley, it can be quite nice. I've played golf and skied in the same day in Utah.
Wow.
Right. So I would say, when we also look at other nations, the Scandinavians usually do very well in their healthcare because their culture is one of fitness, of activity. And it doesn't mean that they're all like, Swedish bikini models. Like they have a walking day. Sunday is a walking day. So you'll see whole families out walking, just to walk, like for no other reason other than it's the expectation that you're going to walk today. And they use mass transit. They use bicycles. Now I get it. Norway's a country of 5 million, right? And New York City is a city of 12 million. Right. But in the same vein, you see this as a inculcation of fitness and activity is important. You go to Asia and the same thing. You'll see 90-year-old grandmothers out on the beach doing kata. because it is what is part of their culture. This is what we do. This is how we maintain our bodies. And I think those conversations are really important to have with our patients of, if you want to be here into your 90s, well, the investment starts in your 20s. So taking care of your body, like, less fried chicken, more grilled chicken, right? And more activity, less TV stuff. And I would say, our kids, like, that is a prime target, because electronic devices and mobile apps and video games is going to rob them of their life later on.
I love everything you're saying. I mean, just like when we reconnected, I feel like we're having a conversation with myself, because everything that I feel, you echo it, and everything that you're saying, I echo it. Right? It's beautiful, and you're so right. You're so right with it, with the culture, and even the I want to say the eye opening. So for me, you remember, I was an overweight child, right? You remember that.
Me too.
Yeah, that's right. We were big boys, right? We were both offensive linemen and defensive linemen on football teams. And I remember it was when I was in my early 20s. I was about 23, 24 years old. And that's when I first started working in healthcare. And I looked at my patients, and I kind of looked at it as like looking into a crystal ball. And I saw the patients who were coming on to my services, providing in-home care support, that I would consider too early to be coming on services, in their 60s, in their early 70s, maybe even in their late 50s. The one thing they all had in common is they were all morbidly obese or way overweight. Whereas the people coming on services needing additional support, when I feel someone actually should, which is beyond life expectancy, your 80s, 90s, and beyond, that's when somebody should really need another person to come in and actually provide care for them. Those people led a healthier lifestyle. So it's just, and that's what caused me to make my change. That's when I lost the weight and have kept off I was like 350 pounds. I have not since taken one day over 250 pounds from that day, like it's wild. So I love what you're saying there. So just another question here that I have for you. We talked about expectations. What is something that you would say we can do to better serve our veterans from a healthcare perspective?
Wow. You want one thing, huh?
Take as much time as you need. Give us the list. We want to know.
I could tell you what's frustrating to me. And in a profit-driven healthcare system, which is the United States healthcare system, we need to understand that it is a pay-to-play system. So just like some people say, what's justice? Justice is how much you can afford. Healthcare is how much you can afford as well. And it is heartbreaking to see some of these veterans who need this care and it's unattainable for them. And it may be unattainable not because the care is unavailable, but they can't get there because they don't have a ride, right? Or they're home, they're shut-ins, or there's no family to support them. And these are the critically endangered people in our population that, in my opinion, have often served their country for their lives, done 30 years, 27, 25 years, 20 years, whatever, and had some event in their life that was catastrophic, that put them in a financial situation that prevented them from moving up and moving forward. And I would love to see more charity work done for these folks. I do love our active duty population. I do love our Homes for Heroes, and I do love our Tunnel for Towers, and I do love our Semper Fi, and I do love our Wounded Warrior Project. I would love to see the Wounded Old Warrior Project, right? I would love to see the homes for 90-year-olds who are living on Social Security alone, no car, getting Meals on Wheels. And honestly, transportation is the biggest thing. Getting folks mobility to move around. I don't know if anybody's ever seen this, but I have been on street corners and watched a man sit there in a wheelchair, knowing he has to cross and knowing that he doesn't have the physical strength to push that wheelchair's wheels across 6 lanes of traffic, and just sitting there in this perplexed but just helpless situation, and knowing who he used to be at one point in time, and that is heartbreaking. So that's a little bit of a rant, a little bit of a soapbox, but that would be my one if I could ask the audience how to help vets mobility.
Thank you so much for sharing that. That is, it's interesting. And I think about with that, I know every state, every place is different. I know here in Monmouth County, where I live in New Jersey, they have the Senior Citizens Adult Network Scan. And a huge part of that is the shuttle bus that they provide, and they will do it for free for somebody who doesn't have. They ask for $1, and most people pay because it's $1, but they'll shuttle people everywhere. But that's one area you have to know about that resource. It's not like it's this thing that everybody is aware of, and so maybe there's 1,000 seniors taking advantage of it, but we have 15,000 that live in this area that, you know, the majority are not even aware that it exists. And if they all were to use it, I know it would tax its to its breaking point. So
yeah, certainly, I would say Monmouth County, absolutely. Let's go over to Bergen County, Camden County, Gloucester County, right? So areas that we know are underserved that don't have
the resources.
Exactly right. It comes down to how much healthcare can you afford, and or how sick can you afford to be, and there's folks that we don't even see that they just kind of fade into the background. You know, they're just part of the crowd, and I see them in the emergency department because that's where they end up. There's no other place for them to go, and some of the stories are just tragic, heartbreaking.
All right. Well, thank you so much for sharing that. I know I have many interesting conversations with the members of my Elite Academy, and we talk a lot about this type of stuff. And some of the things that did just recently, like 4 weeks ago, we were talking about how several members are doing transportation services complimentary, and how it's helped them to be able to serve the underserved population. So it's something that I would like to see more people do.
Sure.
It's something that is there. So as we're wrapping up here, because I'll ask you a fun question in a second, but is there a resource? Is there a nonprofit or something that you are aware of that we can reach out to get more involved in this? Or what would you recommend if somebody wants to get more involved and be part of the solution?
Yeah,
what should we do?
I would go to the VFW and the American Legion. As a member of the VFW, I do get the correspondence about veterans healthcare. Another good source is MOA, so Military Officers Association of America, and they are fighting for veterans healthcare almost daily, because it is an important topic to them, and they take it as a call to arms that needs to be answered. So those three organizations, I would say VFW, MOA, I see that stuff all the time in my email inbox and in the magazines that get sent. And then sometimes the American Legion I see as well.
And MOA was the Military Officers
Association of America.
Association of America. When you were saying it, I wrote them down. I'll make sure I'll make a note later on, and we'll put the links to the websites.
Sure.
When we share this out, because I'm sure people will want to get involved. I have a couple of members of the Elite Academy. One of them served for many years, and he's heavily focused on serving the veteran population, and he's I almost said stationed. He's located in Phoenix, Scottsdale. So he's branching out, and his whole mission and his entire operation, not that he doesn't serve just the elderly population, he does, but I'm gonna say about 80% of his patients are military veterans. And so I know when he sees this, I'll make sure I put him in touch, and he might even ask to reach out. Would it be all right if I share?
Sure. Absolutely. Yeah. I mean, be more than happy to.
Excellent. So last question I'll ask of you, a fun question, a light question. So being in the Navy, you obviously get to travel the world, and obviously the different purposes and whatnot.
Right.
Some places are better than others. So of all the places you've been to, what is your favorite place that you've been to, and why was it your favorite? What was it like being there? How long were you there? Go ahead.
I would say my favorite place that I've ever traveled had really nothing to do with the military, and that's the Yellowstone. it's just captivating. If you've never been there, there's a reason they call it the American Serengeti. And so that would hands down my favorite place on the planet. As far as military orders go, probably Norway. And the culture is awesome. The people are just incredibly hospitable. We had a company of Marines there, and it was over Christmas, and the Norwegians basically adopted these Marines, and brought them in their home, fed them gifts, Christmas gifts for people they didn't even know. But that was the expectation of the Norwegian culture. They're incredibly active people. They're physically fit. It is a maritime culture, right? So it's Viking culture, so it blends well with the naval heritage. I just had a great time and would go back in a nanosecond. So duty on the equator, it's not on the list.
I've been on the equator even for my ties, and while it's beautiful, I do understand that hot heat. And like, it's funny, then the sun sets, but then you got the humidity left over, and you're still roasting. So I
there's nothing on the equator that I dropped that I'm going to go back and look for. So,
well, I love it. Well, again, I'm so grateful to have you here. I know the listeners are grateful to have you here. This is going to be fantastic. And I hope one day, I know we've talked about having you speak at an event. I'd love to one day have you come to one of my boot camps and speak to the audience live and just, again, share some insights, give some encouragement to lift the spirits and let the people who are providing the services, let them know that what they're doing is appreciated, and to continue to do the effort,
I would be honored. As we advance down this path, I find less and less people going into medicine for the right reasons. And the people who really need the healthcare aren't going to get it because people are not attracted to it, right? I don't see a lot of geriatricians coming up. I don't see a lot of primary care doctors coming up. See a lot of orthopedic surgeons, a lot of spine surgeons, a lot of people who see a great way to make a lot of cash in a short period of time. And there's nothing wrong with that. But we need folks to take care of me, you, because we ain't far from there. We're closer than we think. And we have a personal interest in having good people in medicine. So I'm right there with you.
I love it. Everyone, oops, sorry, wrong hand. Thank you so much. Yeah, I got to make sure I do it right? Got to get the right hand there. So, but again, Joseph, Dr. Katura, thank you so much. It's been an honor, my friend.
My pleasure. I look forward to interacting with your folks at the boot camps in the future.